करके रख ही दो।
और
रूम पे कौन आ गया? रूम पे कौन आ गया? रूम पे जूम पे हाँ समझाने नहीं देखे अभी तो वही बताएगा उनको तो कोई नहीं पर उनको अच्छा से बोला था मैं दबा दबा मैं गाड़ी भेजूंगा सुबह फोन उठा लेना क्या बोले अभी लोग डरते हैं आने से मुझे लगता है बोलना पड़ेगा कुछ
good morning and welcome to all for Ignite AICon 2023, a live ENT surgical workshop which is being held at Mahatma Gandhi University of Medical Sciences and Technology, Sitapura, Jaipur. The purpose of this workshop is to ignite you all along with us for the magnanimous and one of its kind AICon 2023 Jaipur. It is the National Conference of Association of Otorhinolaryngologists of India. The National Conference AOICon 2023 promises to deliver a never seen before academic event along with beautiful cultural experience. AOICon 2023 is committed in delivering holistic experience in terms of science, accommodation, culture, food, and social interaction. Kindly register yourself for the same at the earliest if you haven't as of now. The registration details and the details of the conference AOICon 2023 Jaipur are available on the website www.aoicon2023.com. The organizing chairman of the conference is Dr. Manprakash Sharma sir, and the organizing secretary is Dr. Tarun Ojha, who is also the organizing chairman of today's live surgical webinar, which is held at Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. We also have a very dedicated and committed team of working members to make this event a grand success. Now, I would also like to invite Dr. Satish Jain sir, who is an esteemed host for AOICon 2023 Jaipur and will also be performing the live surgeries today in Ignite AOICon 2023. To begin today's session, now I will request all the residents who are the cornerstone of our ENT department, just like every other resident in every other department of ENT, who aspire to learn, work hard for developing the future of ENT, and for whom we have dedicated this Ignite AOICon 2023, a live surgical workshop. So kindly come, light the lamp, seek blessings along with Dr. Tarun Ojha sir and Dr. Satish Jain sir. I would request all the residents and sir to kindly go for lighting the lamp. Thank you.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, sir. Thank you, all the residents. Thank you, sir. Thank you, all the residents. Now, I would request the organizing chairman of Ignite AOICon 2023 and the organizing secretary of AOICon 2023 Jaipur to kindly come and speak few words on this occasion.
Good morning. Firstly, I would like to extend my gratitude to all my seniors, my colleagues, my juniors who have taken their precious time out on a Sunday to be here with us for this live surgical workshop. I truly appreciate your presence here with us. I would also like to take this opportunity to invite you all for the AOICon 2023 Jaipur to be held from 2nd of Feb to 5th of Feb 2023 at BM Birla Auditorium, Jaipur. We as organizing team are putting immense efforts in making this conference a huge success. We are in the process of inviting the most renowned and experienced faculty, both nationally and internationally, to put together a perfect academic event to boost and update your skills and knowledge. We have taken special care to make your stay a very pleasurable and memorable experience, along with local, that is Rajasthani delicacies to savor your palate. I would request you all to kindly register for AICon 2023 Jaipur at the earliest to avail maximum benefits and to not miss out on this opportunity. Looking forward to hosting you soon. Also, we will be hosting similar live surgeries and hands-on workshop. Therefore, do stay in touch with us. Also, for regular updates, kindly visit our website, that is www.aicon2023.com. Wishing you a pleasant learning Sunday. Thank you. Be with us.
Thank you, sir. Thank you for those kind words and telling us about the National Conference AICon 2023 Jaipur. So today's program, Ignite AICon 2023, is workshop which is solely dedicated to ENT from basics to advanced. Satish Jain sir will discuss the preoperative evaluation, surgical techniques, and the postoperative rehabilitation. Also, I would request all the delegates, as they are most welcome, to post their queries, which will be answered by Satish sir. To begin, we have a list of 8 cases lined up, and the details of all will be explained before each case. The cases range from cochlear implant, nasal surgeries, otosclerosis, parotid, and so on. Now, I would request Dr. Vaishali, my colleague, to talk about the first case in detail. Thank you.
Let's start this marvelous day with the first demonstration, which is the cochlear implant surgery, which will be demonstrated by Dr. Satish Jain sir on a patient named Baby Shivya, who's 2 years, 7 months old, female. Sir will talk about the prerequisites to surgery, the surgical techniques, and various factors to be considered during the surgery and after the surgery. The moderators for this session will be Dr. Satish Jain, Senior Professor and former HOD of SMS Hospital. He has a past of 27 years in SMS Hospital, Jaipur, and is a pioneer in otology and neuro-otology, and has multiple publications under his name.
Hello, you are not audible.
Chota karo. Continue karo tum yaar.
Has various talks at national and international level. Next is Dr.
Dinesh, she is not audible.
Hello, hello.
Hi, sir. Yeah, it's slightly better now.
Okay, sir.
Sir, can you hear us?
Yes.
Yes, sir. She is audible, sir. Okay,
Bolo
Sir, second moderator is Dr. Kapil Sikka, who's additional professor of ENT department in AIIMS, New Delhi. His fields of interest is otology, neuro-otology, and cochlear implant. And he's also a member of the Cochlear Implant Group of India and has published many research work in cochlear implant. And third is Dr. Monish Grover, who's done MS-ENT from AIIMS and is presently as an associate professor in SMS Medical College, Jaipur. His areas of specialization are cochlear implant, endoscopic skull-based surgeries, and has demonstrated various live surgeries and cadaveric dissection. And he's also a joint secretary of Cochlear Implant Group of India. Now I would hand over to Dr. Satish Jain, sir, for the demonstration. Thank you.
Good morning, all. Am I audible?
yes.
Good morning, all. So first of all, I invite you again on the behalf of the organizing team of AOICon 2023. This workshop is, aimed to ignite the scientific activity for the upcoming mega conference. And for this conference, our organizing team, led by none other than our organizing chairman, Dr. Man Prakash Sharma sir, and the most dynamic Dr. Tarun Oja boss, who is the secretary for the upcoming organizing conference. And they are doing everything to make it a mega successful conference from the academic as well as many other angles. So thank you once again for joining us to be part of this scientific activity. And I can see on the screen our own teacher, Dr. Sunil Samdani sir, who has been my favorite teacher since my residency. And I've been learning from him time to time whenever I get opportunity to interact with him. Thank you so much, sir, for being with us. And I believe Dr. Kapil Sikka and Monish are going to join us soon, who have been, instrumental in initiating and propagating cochlear implant program in India. Monish, especially in Rajasthan, has done number of implants and trained many surgeons in Rajasthan. So hoping to have them soon with us. So this upcoming AOICon 2023, you can imagine the enthusiasm from the organizing team for organizing or announcing to organize multiple academic events before the mega conference. And I can see on the screen the most dynamic AOI secretary, Dr. Kaushal said, hello. Hello, Kaushal.
Hello, sir. How are you?
How are you? Good. Good to see you. So
yes,
the
sir.
team
All the
AOI,
best for this.
thank you.
Ignite,
the team AOI is
IOCON.
doing
Yes,
everything to take the academics in the otolaryngology at a different level. And we can see time to time activities from the AOI, some innovative, surgical workshops and activity from the AOI, which we have never seen before. Thank you, Kaushal, for doing all this. So regarding 23 conference, which Jaipur is hosting, the organizing team, as I said, as we heard just now, our organizing secretary, Dr. Tarun Oja, has been doing tremendous efforts to make it something, something never before kind of a conference for the AOI. So we invite you with our both hands folded for the upcoming AOICon 2023 to the Jaipur. Today's workshop is, the beginning of the upcoming series of workshops to ignite the scientific activities for the upcoming national conference. And this workshop, wherein we are going to discuss some basic to advanced situations. We are going to have number of cases to start with the cochlear implantation first case, with many other rhinology and head and neck procedures. Hopefully till 5 or 6 o'clock this evening. Then, as our Dr. Tarun Oja boss has announced, we'll be having series of hands-on workshops also before the AOICon 23 to make it memorable for the junior colleagues to give them hands-on experience in Jaipur. So thank you, boss, for all the efforts. And for this case today, there's a young child having bilateral profound sensorineural hearing loss and has been chosen as a candidate for cochlear implantation today. Though, of course, we are doing unilateral implantation. We all know bilateral implantation is the state of the art now in the present scenario. So as far as the cochlear implant is concerned, we all know ever since it started, it has gone, tremendous development, not only in the development in the surgical technology, but in the development of instrumentation, better understanding of the anatomy of the cochlea and further higher auditory pathways, better development of the technology in terms of various, innovative electrodes and implants, more and more options for the different category of patients who are candidates for the implantation. So this science is developing like anything. One of the fastest developing field in the medical science, I would say, in the past couple of decades. You can imagine when this cochlear implantation started few decades back, the indications were very limited for selected children, prelingual deaf children with certain degree of hearing loss above 85 degree or so, with certain, criteria for to be candidate for cochlear implant. But with the advancement in the technology, advancement in the development of this science, the indications have been expanded, and now by and large, any candidate, irrespective of the age, irrespective of prelingual, postlingual, whatever scenario, any candidate which is not benefited by hearing aid for the sensory neural hearing loss is by and large a candidate for cochlear implantation, provided the basic functioning unit is intact. This is very important for everybody to understand the indication, the basic functioning unit for the cochlear implantation. And for cochlear implantation, this basic functioning unit is what we are implanting. We're implanting the electrode to stimulate the nerve endings in the cochlea, wherein the cochlea has become non-functional. So in order to, for the implant to be successful, what all we need is a intact fluid-filled cochlea and an intact eighth or the cochlear branch of the eighth cranial nerve. That is very, very essential for an implant to be successful. And a fluid-filled cochlea and the intact cochlear nerve. These are the two important prerequisites for a cochlear implant to be successful, functional, and effective. So this is very important. So for choosing the candidates for implantation, as I said, the indications have been expanded. Not only for the prelingual deaf children, adults, even the elderly patient. Age is no bar in the present scenario. Even the 80-plus-year-old people have been implanted who want hearing. Provided the basic functioning unit is intact, they are fit for the medical side and all that. So anybody can be implanted where the hearing aid is not working, provided the basic functioning unit is intact. For this, a lot of other workup is required for this implant to be, optimally effective. For children, we have more, selection criteria as compared to adults. For prelingual children, where the speech is the main, factor, the development of the speech is the most important factor. In the parents' involvement, their medical workup, their audiological workup, their radiological workup, there's so many, immunization workup, and all these things are important for carrying out a successful cochlear implantation. So, as far as the workup is concerned, as I discussed, you can see the CT scan on the screen. The radiological workup is very important. Similarly, audiological workup is very important in order to choose a good candidate for the successful cochlear implant. Then, as I said, immunization workup is important, particularly for children, to prevent post-cochlear implant infection, particularly pneumococcal infections, which are dreaded infection, can lead to meningitis and even life-threatening. So everything is important, and particularly for the children, the parents must be committed for the overall better outcome for the implant as far as the speech development is concerned. So a lot of sessions are spent with the children, their parents, in order to prepare them for the surgery and the post-operative rehabilitation and the overall outcome. So it's overall a teamwork wherein audiologist is a prime member or the most important member, I would say, beside the surgeon for this overall successful program, cochlear implant program. So before I go to the radiological part, anybody, Sunil Sandani sir, if you want to say anything or any questions or anything before we proceed to the important radiological part.
Yeah, Satish, I just wanted to add, when you say that all the candidates who are not benefiting out of the hearing aid are the candidates irrespective of the prelingual or
by and large, yes.
So I would just like to add that the hearing aid quality should be a top quality hearing aid, which has a proper gain for the severely or profoundly deaf children or moderately severe. Because appropriate fitting of the hearing aid and the trial of the speech therapy perioperatively is important to eliminate unnecessary cochlear implantation in some cases. So it should not be a just routine hearing aid and speech therapy. It should be a properly fitted, appropriate hearing aid.
Yes, that's a very important message from sir. See, cochlear implant cannot be a replacement to the hearing aid. It cannot be anywhere close to the quality of hearing what we get from a good hearing aid. See, cochlear implant whatever hearing it provides has a narrow spectrum. The dynamic range of hearing what we get from the cochlear implant is very narrow as compared to the acoustic hearing we get to the hearing aid. So hearing aid cannot be replaced by cochlear implant. So as long as the hearing aid work means the best available hearing aid, if the patient is happy with the hearing aid, with the quality of hearing, cochlear implant is nowhere indicated. So that has to be very, very clear. Now coming to the radiological part, why it is important for the surgeons? The radiology is important for the radiologists. Why we surgeons are so concerned about the radiology? Because we want to extract the maximum anatomical details, which is useful in carrying out a successful and a safe surgical, operation for this particular patient. So from radiology, if we take the, the kind of radiology required, what all we need is both a CT scan and MRI for the different indications. CT scan is important to give you anatomical details of the temporal bone, particularly bony details, which are important to know in carrying out surgical operation in that area. You need to know the three-dimensional anatomy of that area, particularly the anatomy of the cochlea and the surrounding structures, facial nerve, facial recess, so many things, vascular anatomy around. All those things are important in carrying out a proper operation. Similarly, MRI is important. As I said earlier, we need to know the basic functioning unit intact for a candidate to pass, eligibility for a cochlear implantation. That is the cochlea, which should be fluid filled, and the intact eighth cranial nerve or the cochlear nerve for the cochlear implant to be effective. And that is best seen by the MRI. MRI is known to give the best soft tissue details, and CT scan is known to give best, bony details. And both have investigations complement each other to get the maximum information before surgical planning. This is very important because many of these patients, particularly children, have malformations, congenital malformation leading to profound sensory hearing loss. Though many of the patients' malformations are not visible even on the radiology, because what we see on radiology are bony malformation. The malformation at the membranous level cannot be picked up by radiology, and still many patients looking like normal on radiology, we may face complications, what we face in malformation. So we have to be in any situation prepared for all those complications, but still a good radiology can give you a proper pathway for a good surgery. So CT scan is important, MRI is important, and we need to know how to read and how to get the maximum information out of which. Otherwise, radiologists are, either you have to make a team with the radiologist to know what all information you know from cochlear implant perspective. If I send a CT scan to a radiologist to report, they will report in single line the normal anatomy of the temporal bone. That is of no use to us when we are planning a cochlear implant surgery. What all is important to us when we are planning a cochlear implant surgery, to know the anatomical details in relation to the surgical procedure of the cochlear implantation, in order to know the anatomical abnormality which can pose difficulty during surgery. All those things which can pose difficulty during surgical procedure, we must know beforehand to plan our surgical technique accordingly. We may have to change our surgical technology according to the the radiological information. We'll discuss during this details of the CT scan. So
Satish boss, good morning. Kapil Sikka here.
Hi, good
I'm
morning.
Sorry I joined late. Yes.
We're waiting for you, man.
I'm sorry, sir. Sorry for delay.
So for everybody, the Kapil Sikka has come in, the most dynamic, who has been committed otologist and one of the pillars in taking this cochlear implant program ahead in the All India Institute of Medical Sciences, the prestigious institute of our country. And Kapil has been always been academically oriented and committed to teach each and everybody. So Kapil, we would like to have your comments.
I have been listening to you, sir. I think
of everybody.
I have been listening to you, sir. Listening to you and Samdani, sir, for some time now. I just wanted to ask you and engage in discussion. Many patients, they come to you with a CT scan that is 1 year old or 1.5 year old, and they come to you for implant now. Do you repeat it, or do you take it at value, the old CT scans?
Yes. See, I have already mentioned the CT scans are, ordered to get the anatomical details, 3D anatomical details. So if somebody is holding a CT scan in hand, what all I will request him to have a digital information. I want the CT scan in digital data to extract 3D information, because in digital data, I can convert to 3D and get three-dimensional anatomy. But sometimes what happens, the patient brings the CT scan printouts. To me, those are not adequate to get best information related to my surgical procedure, because that's what I'm going to put forward, the kind of CT scan we need and kind of CT scan, person should order to get the maximum information. So your point is valid, Kapil, and that's what I'm, starting, that what all is required to know from CT scan. If the patient is carrying CT scan with all that information in hand, why to repeat unnecessarily? The anatomy is not going to change at all. But what we want to know, whether the CT scan is adequately, done, whether we have complete information from the patient what is having CT scan in hand. So
Right.
That's why we order always CT scan in digital format. And with our software, we can reconstruct to all planes to get maximum information. That's the information. That is why the onus is on surgeon to read CT scan on our own, rather than relying on the radiologist's information. We want anatomical details. With this, software, we can measure the anatomy in some millimeter, fashion, which is important sometimes, very, very critical from cochlear implant point of view. So I would like you to interrupt me any point of time. You want to add on anything? I know anything, a single word coming from you is going to be very, very important for everybody. Thank you, Kapil. And I can see on the screen Dr. Markande Tiwari with us, who is the head of department at the prestigious Government Medical College, Goa. Thank you, sir, for being with us and enlightening us with your experience today. Thank you so much. So before going to the CT scan, as I said, we want a digital format so that, and where I am running my CT scan on this, Radiant DICOM viewer, wherein I can get the maximum dynamic three-dimensional information, which is useful from cochlear implant point of view. CT scan, a high-resolution CT scan temporal bone, has to be read from different ways, from different perspectives when you plan different surgical procedure. For example, if I'm planning otosclerosis surgery, we have a case of otosclerosis today to demonstrate. In that scenario, I will be reading the CT scan from different perspectives to touch upon or to look at those important information which are more relevant from the otosclerosis surgical point of view. Here, I will be reading the CT scan more importantly from the cochlear implant perspective. Anything which is related, any anatomy which has an impact on the cochlear implant surgery, which can change the overall, outcome of the cochlear implant surgery, which can change the procedure of the cochlear implant surgery required. Anything which has an overall impact on the cochlear implantation surgery, we are going to discuss. So what all to be discussed on CT scan? We need all axial, sagittal and coronal planes, where our radiologist, shoot the CT scan in the axial plane always, and you can see it is fine section, submillimetric 0.6 mm at the left lower end. You can see 0.6 mm sections. We have 196 images. You see the area scanned by this, and with this software, I can convert this to three-dimensional now. This is a very important teaching tool for the junior colleagues as well. If you are reading the CT scan this way, and you can read the anatomy in all three planes. For example, if I take my cursor in the axial section on the basal turn, you can see in all planes where the basal turn is, and this improves your overall understanding of the CT scan in three planes. So this is an amazing teaching tool, number one. Number two, it gives you dynamic information. For example, what do I mean by dynamic information? If I want to see the facial nerve course, if I want to see the cochlear turn, I can see dynamically the CT scan through this, DICOM format. See the facial canal, the vertical facial canal, right from the, the foramen, the external foramen, the stylomastoid foramen. I can see the entire course of the facial nerve, how it is traversing through the temporal bone, how it is in relationship with the various important structures like lateral semicircular canal, the round window, how it is important to all these structures. And this is important from cochlear implant perspective. So we need to know what all to be seen on CT scan during cochlear implantation, though I'm not going to be in very details as the patient is, being prepared. So I will touch upon quickly the important things to be seen on CT scan from cochlear implant perspective. So this is axial section. I will mention every time what all to be seen on axial section, which gives best information, what all for information which is gathered best on coronal as well as sagittal sections. So we need to know all that information. Now, so I am running my CT scan from top to bottom. Kapil, am I audible to you?
Yes, sir, perfectly.
So feel free to interrupt me anytime, dear.
No issues.
See this, I am running from top to bottom, and every time I move, this is 0.6 mm slices. Every single movement, I will be moving by 0.6 mm. That is beauty of fine section. If suppose I have a 4 mm, 5 mm CT scan, with every slice I will jump by 4 or 5 mm. That will be too inadequate, in terms of giving information in temporal bone, wherein a sub-millimetric anatomy can change the overall scenario. Now see, the first structure to be seen is the superior semicircular canal, the non-ampullary end and the non-ampullary end of the superior semicircular canal. You can see here. See this again. The superior semicircular canal to begin with, then this ampullary end, non-ampullary end. You can follow the ampullary end. This is important. Though the superior semicircular canal per se is not important from cochlear point of view, this is more important, we will see in a otosclerosis point of view. But for everybody's information, this is best seen on coronal sections. Let me show you. The lateral superior semicircular canal is best seen on coronal section. Can you see my cursor? That is the vestibule. See all the three canals, the lateral canal going laterally here towards the mastoid hair cells. This is superior canal going towards the middle cranial fossa. And if I want to see the dynamic superior canal, the full course dynamically, see this. See the bone over the superior canal which is intact. That is important to know if there is any superior canal dehiscence. I told you that is more important, more relevant from in otosclerosis surgery than in cochlear implant. But any malformation of the semicircular canal is very important in cochlear implant surgery. If there is any malformation in the semicircular canal, we must be prepared to see the abnormal course of the facial nerve. That is important. Facial nerve is an important, anatomy in cochlear implant surgery, and to protect the facial nerve is a very important part of the surgery. And facial nerve malformation, abnormal courses are common once there are malformation of the semicircular canal. So in CT scan, the first thing we see any malformation of the semicircular canal. See, this is superior canal and forming the vestibule here. This is vestibule. Now coming back here, what all we see here during this course, what is this? This is round window. This is round window here. This is round window. That is the cochlea. That is round window. That is the facial nerve here underneath the lateral semicircular canal. So best thing to see the semicircular canal, all the three canals together dynamically. To see any malformation, we need to look at the coronal picture. That is one important thing we can make it. So this is one thing to point out, and we should not miss any malformation of the canal, particularly lateral canal. Lateral canal malformation are almost always associated with facial nerve malformations. Now, coming down, See this. This is superior canal. I'm coming quickly down. What we see here is the vestibule. This is the vestibule, and from the vestibule, both the ends of the lateral canal looking like a signet ring. Can you see this? That is the ampullary end of the lateral canal. That is the non-ampullary end of the lateral canal. And this is very important anatomy here. This is vestibule. That is lateral canal. We need to see all the canals together. This is posterior semicircular canal. See, this is vestibule. Looking at the orientation of the cochlea in the body, this is lateral, this is anterior, this is posterior. And what we see, this is the posterior semicircular canal, again emerging out from the vestibule. This is the ampullary end of the lateral posterior semicircular canal emerging out of the vestibule. Another thing to be important and looked at is the vestibule. The dimension of the vestibule is very important. See, many a times in many of the malformation of the inner ear, the enlargement of the vestibule is one of the associated malformation along with the cochlear malformation, and we need to be very careful not to overlook this anatomy if it is enlarged. An enlarged vestibule and an enlarged vestibular aqueduct. Can you see this? This is the vestibular aqueduct. Can you see? This small. See this, this is vestibule. From the medial wall of the vestibule run the vestibular aqueduct, which houses the endolymphatic duct, which opens at the posterior petrous surface. This is the vestibular aqueduct. We need to see in all our CI patients very carefully if there is any enlargement of the vestibular aqueduct, like which is common, in Mondini malformation, wherein there is an incomplete partition of the type 2 of the cochlea, and vestibular aqueduct enlargement. Vestibular enlargement is seen in IP1 as well. And the importance of the vestibule and the vestibular aqueduct enlargement is maybe associated with, gusher, not gusher, but at least oozer, because this endolymphatic duct or enlarged endolymphatic space is responsible for transmitting the CSF pulsation, which may result in sensory hearing loss and which may result in pulsations of the perilymph when you open the inner ear, when you open the cochlea, and can result in some sort of oozing, sometime even in gusher as well. Uncommonly, gusher is most commonly associated with abnormal communication of the lateral end of the canal with the cochlear base. So what we have seen so far, the semicircular canal, the vestibule, the vestibular aqueduct, everything is important. Now, as we go down, another important thing we need to look at this point of view, this is internal auditory meatus. A normal size internal auditory meatus is something which is safe for the cochlear implant patient, safe and important from different point of view. Let me change. What do I mean by normal size? With this software, I can measure the dimension. See, the dimension is 4.4 mm, which is normal dimension of the intra-auditory meatus in mid segment. Now, what happens? Sometimes this intra-auditory meatus may be bulbous, dilated, and should warn the surgeon of having abnormal communication with the cochlea to give a gusher. See, all these things which can give rise to gusher, one must be prepared with to deal with it, because gushers can have impact on the surgical procedure. In overall surgical planning, there are many situations wherein the gusher is imminent, which you can pick up by the radiology, like in IP1, common cavity, IP3. Those are the situations which are more likely to give gusher, wherein the stopping the cerebrospinal fluid egress is very, very important. And many a times in high risk individual, we change our surgical technique to a subtotal petrojectomy implantation, which gives us the best technique to tackle the CSF gusher. So all this anatomy, all this CT scan has a relevance on choosing the surgical technique as well in difficult situations. So the role of the CT scan, as I said in the beginning, is to know any difficulty one can encounter. You can preempt by the CT scan if somebody is going to encounter any difficulty which can have a significant impact on the overall surgical procedure. Now, besides the cochlear implant, now the other important thing, once we look at the intra-auditory meatus, see, if I look at the intra-auditory meatus here, there are so many things which are emerging from the intra-auditory meatus. The first thing, see here as well, this is intra-auditory meatus. If I come from top to bottom, the first thing coming anteriorly from the superior part is the facial nerve. See, this is the facial canal. That is the labyrinthine segment of the facial nerve. If it is clear to you, hope it is clear to you.
Yes, it's clear.
That's the labyrinthine segment, and you can see dynamically that is the first genu. That is the horizontal segment. As I go down, that's the horizontal segment of the facial nerve here. And if I go down, you can follow with the second genu and then the vertical segment. This is best seen on a dynamic CT scan where you can relate three-dimensionally everything. Kapil, you asked me in the beginning, if patient is carrying a CT scan in hand, would you repeat? If the patient is carrying a printout, I will definitely ask for a repeat CT in digital format. But yes, if the patient is carrying already in a digital format, there is no point in repeating a CT scan, and the anatomy is not going to change. But we need a complete in-depth three-dimensional information of the anatomy, which can only be gained optimally by a digital information, a digital, data of the CT scan. Do you agree with me?
Yes, sir. Totally agree.
So this kind of, this dynamic information is required where every structure you can relate dynamically to each other. So this is the level of the CT scan. In as I said, in abnormalities of the semicircular canal commonly, and sometimes in the inner ear abnormalities like common cavity, in a cochlear hypoplasia, and sometimes in other abnormality, this facial nerve location may be abnormal, and one should be prepared to look at it by a preoperative CT scan and accordingly deal with it intraoperatively to prevent a damage to the facial nerve. So this is important to look at the CT scan, the anatomy of the facial nerve, the entire course, right from the labyrinthine segment to the labyrinthine segment here to the, this is horizontal segment here. That is on the right side. That is second genu, and this is the facial nerve here at the vertical segment. Now, there are a lot of discussion about, looking at the facial nerve in view, as the commonest technique of the cochlear implantation is posterior tympanotomy. And people have described n number of ways to see the visibility of round window through the posterior tympanotomy, whether it is a favorable round window or not, because the anatomy of the round window, orientation of the cochlea is different in different individuals. There are a lot of, publication describing the orientation of the cochlea. Let me tell you what exactly we mean by the orientation. See, this is the sagittal plane, and if I make a line traversing the basal turn of the cochlea, the length of the basal turn of the cochlea here, see, exactly that is the angle we want to know. That a lot of people have described this angle. More the cochlea is obtuse, more the angle is narrow, both the ends give you difficulty in visualization of the round window. Difficulty. With experience, you can overcome easily all these difficulty, but this is important to, as far as the teaching is concerned, these are important discussions so that you can be more prepared in dealing with difficult or unfavorable round window. Unfavorable means, by and large, to be very precise, we want to see the round window through the posterior tympanotomy, through which we can, by round window or extended round window or whatever approach, we access the scala tympani of the cochlea, basal turn of the cochlea. Now, if the round window is unfavorable, it is not visible to the posterior tympanotomy, is a difficult task then how to approach the cochlea. One can get disoriented, or one may implant the, the cochlear implant outside the cochlea somewhere, or, misplace the implant into different locations. So in order to know the surgical difficulty, whether the round window will be favorable or not during surgery, the simplest way, there are hundreds of ways, you can see, and see one of the ways you can easily see. Let me show you take you back to the facial nerve. See, this is the facial nerve again, the horizontal segment of the facial nerve. And if I am going here, following, see my cursor is following the facial nerve here in the vertical segment. That's the vertical segment of the facial nerve. Can you see this? Can somebody remove this? Boss, Dinesh ji?
Yes.
Yes. Yeah. See, this is the vertical segment of the facial nerve where my cursor is. I hope it is very clear.
Yeah.
So this dynamic CT can take you directly to the structure which you want without disorienting you. That is another beauty of having the CT scan in a dynamic way. Now, this is the basal turn of the cochlea. In the long axis of the basal turn, you are supposed to implant. Now, how you are coming in the posterior tympanotomy? Suppose, let me tell you the angulations. This is the long axis of the basal turn of the cochlea where we need to implant. Okay. This is the facial nerve. In posterior tympanotomy, facial nerve is a medial anatomy. Posterior tympanotomy is a triangular space between the lateral canal, the extra-auditory canal laterally, and which is demarcated at the medial end by the chorda tympani, and the facial nerve medially, that triangular space. Now, if I draw a parallel line through the anterior wall of the facial nerve, see this? My facial nerve, this line is the medial limit of my visualization, which I am looking from laterally here. And the second line, the anterior line of the visualization is the extra-auditory canal. Look at the extra-auditory canal here. If I draw another line parallel to the extra-auditory canal, in the way I am going to see from behind. See this parallel line? See those two lines. Imagine surgically where you are doing a posterior tympanotomy, wherein my lateral limit or the anterior limit here is going to the chorda tympani demarcated by the medial end of the extra-auditory canal. This is the medial end of the extra-auditory canal here. And my medial line, my medial limit is going to be the facial nerve, which is the second line here. Through this visualization, through this, I need to seek into the long axis of the cochlea. If the long axis of the cochlea falls between these two lines, by and large, your round window is going to be visible through the posterior tympanotomy. Got my point or not? Agreed or not? There are hundreds of ways to, there are so many angulations, so many, formulas have been described by various people, making it more and more difficult for everybody to understand the accessibility of the round window, visualization of the round window or the favorable round window to the posterior tympanotomy. This is what we need to know practically between the line of the extra-auditory canal and the facial nerve, the lateral part of the facial nerve. If through this axis laterally, I am going to see here from laterally between these two lines, if my long axis of the basal turn happens to fall between these two lines, my round window is going to be accessible. Kapil, any comment, or you look at it differently?
No, sir. We more or less use the same method of assessment. Basically, it's the cellularity and the thickness of mastoid bone between posterior canal wall and the vertical facial nerve. And
yes,
you are very right. If your round window is seen within that triangle, then the access will be easy.
Absolutely. So this is one of the practical ways, I would say, to look at the round window. Now see, I can show you, if you see very carefully, let me enlarge where the chorda tympani is. See, to tell you everybody how to look at the chorda tympani. See this, follow the facial nerve. This is horizontal facial nerve. I am going down. This is vertical facial nerve, vertical facial nerve. Vertical facial nerve, vertical facial nerve. Can you see some nerve is joining here? Chorda tympani emerges from the lower part of the facial nerve just before the stylomastoid foramen. And see this nerve which is emerging. Can you see this? This small nerve where my cursor is going. I'm following it up, following it up, following it up. Can you see this small nerve? Yes or not? Can you see this small nerve where my cursor is? Very small nerve. That is the chorda tympani. That is the chorda tympani, and where it is going? To the medial end of the extra-auditory canal. See, this is your chorda tympani. This is your facial nerve. and in between is your long axis of the scala tympani or the basal turn of the cochlea. So that can tell you exactly. See, in the CT scan, I'm looking from laterally between my both limits, the facial nerve and the chorda tympani here, to the long axis of the basal turn of the cochlea. This is what we need to see intraoperatively in cochlear implantation. That is what my submission to look at, how to look at this, important aspect to see the feasibility of round window visualization. Now, coming after this, the another important thing, once you look at the cochlea, see this, the cochlear anatomy, we must know in all the three terms, whether the cochlea is normal in terms of, morphological development. See the apical, middle, and the basal turn all together. Can you see? And this is the section, I would say, the mid-modular section you can see, wherein all three turns of the cochlea are visible. And this is the modulus, and this is the cochlear aperture. See this. This is the intra-auditory meatus again. This is the intra-auditory meatus. And from here, the cochlea is, related to the lateral end of the, intra-auditory meatus. This little bright and ossified, this is porous bone that forms the modulus, and that is sitting at the cochlear aperture, closing this cochlear aperture. In situations where the cochlear aperture, the modulus is deficient, what you can imagine, what is going to happen simply is going to be a gusher. So gusher is totally attributed to the abnormal communication of the lateral end of the intra-auditory meatus to the cochlea. When the cochlear aperture is deficient, the cochlear aperture is widened. When the modulus is deficient, when there is through and through communication of the base of the cochlea with the intra-auditory meatus, the gusher is likely. No single case of gusher has been attributed so far to the abnormal cochlear aqueduct. That's a misbelief. It has been, studied as one of the potential source of, gusher in the cochlear implant surgery or stapes surgery, but the role of cochlear aqueduct is different altogether. We'll discuss in stapes surgery in detail, but we'll need to know where the cochlear aqueduct is and how important it is as far as the, gusher is important. So cochlear aqueduct has practically no role in contributing to the gusher. It is almost always the lateral end of the intra-auditory meatus, which is in abnormal communication with the cochlea because of deficiency at the base of the cochlea at the level of the modulus. When this deficiency is there, the cerebrospinal fluid is in direct contact with the cochlea and it flows freely. Once you open the cochlea at the round window of cochleus mean, you're likely to get the gusher. And this you can preempt quite effectively by means of a CT scan if any of these abnormalities you may find. Sometimes we have seen in a couple of cases wherein there was direct abnormal communication of the cochlea with the intra-auditory meatus with modulus deficient, and yet there was no gusher because we can't pick up the membranous, limitation, the membrane which is separating the cochlea from the intra-auditory meatus, which cannot be picked up by a CT scan. So there could be one of the, fallacies you can see because the CT scan, MRI, whatever we are doing are not going to give you the details of the, the membranous labyrinth at the cellular level. So this is important. This cochlear, see the base of this is cochlear aperture. You can measure with your software the size of the aperture. This should, if it is too big, then can lead to gusher. If it is too narrow, this looks like around 2 mm. If it is too narrow, less than 1.4, it is assumed that could be cochlear nerve hypoplasia or deficiency. There are many other ways to look at that. And the decision making is altogether different. That's a different field. I'm not going in detail. But this is one of the way we must look at the CT scan to rule out all those, possibilities of cochlear nerve hypoplasia or deficiency. So CT scan has to be, seen differently from cochlear implant. Now, another important thing, that the basal turn of the cochlea and immediate anterior structure to the basal turn. See here, what is this? That's the cochlea, that's the carotid artery. See, look at this. That the basal turn of the cochlea and immediately anterior to it is the carotid artery. That's the horizontal carotid artery. That is the vertical genu of the carotid artery. which is in millimetric distance from the cochlea. Sometimes this bone is deficient, and the literature supports, you will find from literature, some of the people have accidentally implanted the cochlear implant going from here directly into the carotid canal. Can be a disaster if you are unaware of it, or if it happens to damage, or while removing it, pulling it back and tear the carotid artery. All those, are different aspects. We need to be very careful. So this cochlear carotid partition, we must look at before every cochlear implant to see if any disaster which can happen. Another important thing, at the level of the round window. See, this is the level of this is the round window. This is the round window. That is the round window niche. See this, how thick the round window niche is we are going to get in this particular patient. We must be prepared to deal with a thick round window niche. Can you see here the thick round window niche? So these are important information we must know during CT scan. And at the level of the round window, if I go below, if I go below, now you see the jugular bulb. Sometimes the jugular bulb is too high, that too uncovered by the bone. See now, we have gone below the cochlea, no cochlea is seen, and now the jugular bulb is coming into the picture. As I go up, see now, as we see the cochlea, the jugular bulb has gone far off with a thick bone between this. So there is no risk of the jugular bulb injury or anything, or any challenge from the jugular bulb side to the cochlear implant surgeon. Another important thing we must see in coronal sections, there are a few things we must look at the coronal section regarding the facial recess, regarding the favorable facial recess or the favorable round window. First is, look at the vertical segment of the facial now. This is vertical segment of the facial now. See, this is lateral canal. This is the lateral end of the canal here. Lateral end of the canal here, and see the vertical segment of the facial nerve. So this vertical segment of the facial nerve is medial to the level of the canal. See that the lateral end of the lateral canal here, it is medial to it. Sometimes the facial nerve is too lateral to obscure the visualization of the round window. We must be very careful. And this was the classification initially proposed by Telmesani to see the difficulty in visualization of the round window. Second is this round window. That is the round window, the distance of the facial nerve to the round window. Again, see this. This is the facial nerve. Follow me. This is the facial nerve. This is the facial nerve. Here is the facial nerve where my cursor is. And see the distance from the round window. What is unfavorable round window? When the round window becomes too medial, when the round window, the facial nerve and the round window distance is less, the round window is posterior-medially directed close to the facial nerve, then the likelihood of the favorable round window is less. You can imagine, you can measure in terms of distance between the round window and facial nerve, whether it is a favorable or not favorable, unfavorable round window. So all these are important. See, for looking at the CT scan to give the optimum results of the cochlear implant, one must sit with the CT scan at least for half an hour to get the exact sub-millimetric three-dimensional information, which can complicate your cochlear implant surgery, which can have a significant impact on the overall implantation, surgical aspect, difficulties, or changing the surgical technique of the implantation. Next is the MRI, and I will quickly, our case is ready, and quickly come to the MRI. The sequence we look at the MRI almost always is the 3D CIS or the Fiesta sequence, or the heavily T2 weighted imaging, wherein you can see the fluid of the inner ear as a bright sequence. In heavily T2 weighted, see the CSF signal bright. Similarly, the fluid in the cochlea is bright. As I said in the beginning, for a cochlear implant candidate, one must have a fluid-filled cochlea. Look at the cochlea, completely bright, fluid-filled with the interscalar partition very, very closely visible between the middle and the apical and the middle and the basal turn. You can see the interscalar participation with the scala tympani and the scala vestibuli, two different segments. The lower one is the scala tympani, the upper one in the vestibuli. Very, very clear on CT scan. That is the vestibular system, the vestibule and the lateral canal. That is endolymphatic sac and the duct. This is endolymphatic sac and duct. the lateral semicircular canal, vestibule, the basal turn, middle turn, and the apical turn, all full of fluid. This is the prerequisite for a cochlear implant to go. In situation like ossification, in situation like post-meningitis, post-traumatic, post-autosclerotic, there are many ways, many etiologies which can contribute to the, obliteration of the cochlea. And in complete obliteration, we know rules out the possibility of a successful implantation, though the surgical technique has advanced now with the advancement in the technique of the, the electrodes, wherein we can implant even the very, very difficult ossified cochlea to certain extent, not optimum, but to certain extent. Otherwise, the ABI is the final answer. And we all know why this is important to know. Even the worst result of the CI is the better than the best result of the ABI. Even if we could push some electrode to stimulate, certain aspect of the hair cells in the cochlea, we can get better hearing and speech recognition, better than the best results of the ABI. Now, how to look at the various nerve? What we need to see from the MRI is an intact cochlear nerve. How to look at it? First of all, dynamically, you can see where the cochlear nerve. This is cochlea, this is modulus, and see from the modulus dynamically, this nerve is emerging. This nerve is emerging and going to the cochlea. This is cochlear nerve. This nerve behind is the vestibular nerve. That is vestibular nerve. See this behind, the fullness behind the vestibular nerve. This space behind the vestibular nerve is the Scarpa's ganglion. The vestibular nerve ganglion behind. You can see very clear. So this is vestibular nerve, very clear. And this is the cochlear nerve. And in order to see the dimension of the cochlear nerve, the best sequence is the sagittal one. How to reach the sagittal section on the MRI? 3D, go to the sagittal, and in the sagittal view, see this is sagittal view. Now I will tell you how to look at dynamically. It's not the static image which is important. Oh, sorry. It is the dynamic image which is important to know whether the cochlear nerve is adequate in diameter. This is important to know because a hypoplastic cochlear nerve can have a significant negative impact on the overall outcome of the cochlear implant surgery. So here, this is our sagittal view. See this sagittal view I have seen here. Let me show you which is the cochlear nerve, which is the, see in sagittal view, you will see four nerves. Four nerves, the picture is not very great, but here you see that is the cochlea laterally. From here, the cochlear nerve is emerging. In sagittal plane, let me take a better picture of the sagittal view. Yes. Yes, this is a much better picture of the sagittal. Can you see the four dots? Four dots of the four nerves. This is the orientation of nerves in the intra-auditory meatus. Now, which is cochlear nerve, which is vestibular nerve? See this. See, this is cochlea, and this inferior nerve is the cochlear nerve. This inferior nerve is the cochlear nerve. This is anterior-inferior. The anterior-superior is the facial nerve. Posterior superior is the superior vestibular, and posterior inferior is inferior vestibular. By and large, how can you make out this is facial nerve? This is cochlear nerve. The dimension of the cochlear nerve is generally bigger than all these nerves, generally by and large. A hypoplastic cochlear nerve is defined if the dimension of this cochlear nerve is less than the dimension of the facial nerve, by and large. Many times you may not find the cochlear nerve separately, yet you can implant with guarded prognosis, and you can find the hearing as the cochlear nerve fibers may be traversing through other nerve. But by and large, if in this particular case, the cochlear nerve dimension is normal. If it is hypoplastic, then you have to take the help of other electric tests. You need to counsel the patient more and more to give a guarded prognosis that in case the cochlear nerve is not functioning, dehiscent, absent, hypoplastic, aplastic, whatever, you may have to change to a ABI, and that can be done intraoperatively as well. So the role of the MRI, by and large, is maximum to give you information about these two information, that is the fluid-filled cochlea and the intact cochlear nerve. Besides, the other sequence of the MRI can give you information about any other pathology in the brain, which can have an impact on the higher auditory functions. So that is another part. You can have a detailed information on the other sequences of the MRI. So our case is ready. Before we move on, anybody, any comment or any questions? Because this was simply how to look at CT scan and MRI from cochlear implant perspective, not getting other information for other surgeries or anything from the temporal bone. So Kapil, Samdani sir, or anybody, sir, please.
Can I add something?
Yes, please,
that,
sir.
When a request is made for the MRI, it should be written that preferably it should be 3 Tesla rather than 1.5 Tesla.
Yes, you can get a better information of the inner ear, interscalar partitions, better information of the initial changes into the cochlea from any other pathology. For example, let me give you, many a times we get post-meningitis patients. Early post-meningitis patient and an MRI is, phenomenal in picking up early fibrosis, early changes, which can turn into profound sensory hearing loss, which can turn into cochlear rehabilitation further. So those changes can be picked up by a 3 Tesla MRI with different sequences in a better way. Any slightest change in protein composition of the inner ear fluid should preempt you of the impending cochlear ossification in a post-meningitis situation. And the sequence we take into consideration for that is a 3D flare. In 3D flare, the cochlear fluid signal is dark, just opposite of the Fiesta sequence. In that situation, if you see any slightest change in protein concentration in the cochlea in post-meningitis situation, you can imagine the cochlear ossification is likely. That is very highly likelihood of cochlear ossification. And that is the time to take a call of implanting. If that is the implant is not possible for the patient affording so many things, you can at least stent the cochlea with a, a dummy implant to keep the lumen intact for the future. So the MRI sequences are very important. Timing of MRI is very important. What sequences can give you best information in the earliest, changes are most important, and that you can pick up in that scenario is by a 3D Fiesta. So your point is valid. A 3 Tesla MRI is more informative than a 1.5 Tesla MRI, definitely.
Jaipur team has been instrumental in bringing out a lot of literature on malformations on radiology. Recently, I saw a book also coming from SMS Monish Group.
Yes.
So it's indeed a proud moment for all there, and very comprehensively discussed, Satish sir. It was very enlightening. I think all aspects were covered in radiology discussion.
May not be all, but yes, important aspect I tried to bring forward.
Almost all, I think.
Radiology is so
definitely
vast because people have, worked a lot. This is technology. Technological advancement is much, ahead than any advancement. A lot of people has brought in various ways to, know the favorable situation of cochlear implantation, round window visibility, so many things, various angles. I'm not denying those are important. Those are important, but those are very complex. But we must know all those situations because those can be helpful in difficult situations. So Kapil, we go ahead with the surgical part.
Yes, sir. Looking forward.
We have some online questions here. Yes, please. Yes.
Sir, I will keep asking the questions.
Yes, please.
There are a lot of questions already that we have. So one of the questions is by Dr. Ajay Panchal. Sir is asking, can you please throw light on how to counsel and to take consent in cochlear implant?
How
to counsel and take consent in cochlear implant?
So the consent is very important. Your question is valid. And our Cochlear Implant Group of India has brought out a very comprehensive consent pro forma for the cochlear implant surgery. Of course, it should be an informed consent. The consent is very important because this surgery is not always a straightforward surgery. The complications are not only intraoperative, but maybe post-operative, maybe delayed post-operative. Some patients even develop infection years after cochlear implant. That should be part of consent. And so this comprehensive consent is proposed by the Cochlear Implant Group of India. You can download from the website, and we must take that comprehensive informed consent from every patient before surgery. Kapil, any other special consent or pro forma from All India Institute?
No, sir. Follow the standard, same whatever aspects you have touched. Cochlear implant is if the standards are not followed accurately, it can be at times a bit unpredictable outcomes, results. So I think checklist maintenance, what you have mentioned, is very important. So consent can be classified into two categories. One is the basic surgical aspect, where you take into consideration the surgical part, the mastoidectomy, your facial nerve, your main surgical risks, and thereafter the second aspect is your outcomes. For example, as we have seen that radiology was not well read, you have missed the cochlear aperture stenosis, or you have missed that nerve was not there, and patient is not able to hear. That can have some serious implications on surgeon's career. So all those things, they need to be taken into consideration. I would suggest you divide the consent into two. One would be the surgical aspect, and second would be the outcome aspect. All the patients who are falling in gray areas, as sir had discussed, that their general workup, their intelligent question, their pre-operative language and speech parameters, their age, and other things, they should be taken into considerations, because the parents' expectations should not be very unrealistic.
Yeah, that's very important. So the consent should be an informed consent and detailed, comprehensive one, because up to 2 to 3%, maybe more than that, patients subject some sort of problems with the implant, because there is nothing in 100% in science. You can assume the cause of sensorineural hearing loss from the cochlea. You are absolutely unaware of the behavior of the higher auditory system. Regarding the overall outcome of the implant, you can imagine, and by and large, we achieve the results, the best results, but still there is nothing 100%.
Secondly, so this is one aspect we need to spend a lot of time on. Sometimes the parents will come to you that child does not perform very well in school. So your implant is not going, maybe not necessarily going to improve on that performance. Maybe after putting implant, the child will not be standing first in class. So that things, they need to be very realistically explained to the parents on what you are going to do and what benefit you are going to achieve.
Yes, that is important. Yeah, are you getting the microscopic picture?
Yes, sir. Yes, we are getting.
So, as I said, Kapil, I'll be going by the traditional posterior tympanotomy route.
Yes, sir.
Many techniques have been proposed to implant with the, every technique has its pros and cons, but this is the time-tested technique which we follow. So first important thing is the incision.
So may I request the organizers, if they can put the questions that they have got in the chat, we can continue discussing them by the time sir goes on with surgery.
So what you can do, Tarun boss, can you ask Dinesh or somebody to send the link of questions to Kapil or Samdani sir? So my incision is a very simple incision, for that matter. Just a small incision, retroauricular incision, with little, superior curvature for our age, you can say, little superior curvature, because I will create a well and do a lot of things to house the implant above. So this is the incision. This is incision. Incision has a lot of relevance in terms of, the wound complications, in terms of, vascular compromise and other things. This incision doesn't compromise anywhere vascularity to any flaps. This region is supplied by multiple vessels. From below is the, the occipital artery, posterior auricular artery. Above, from anteriorly, is the the superficial temporal, middle temporal artery. And this incision doesn't, violate any big vessel coming in the way. So this is a very, very favorable incision we have been using for years. And then I'm going to the thickness of the superficial tissue. See this? Another important thing is we generally avoid, too much of cautery during this surgery, not even before the implantation. The reason is the cautery results in some sort of tissue loss. And in this surgery, one of the major determinant of the wound complication is too much use of cautery, too much tissue loss, which ultimately calls for a tension suture, which can give way and invite infection. So our aim in this surgery is, our recommendation is to use less and less cautery.
That's very relevant point, sir. I feel that in any otologic surgery, I think cautery use, especially monopolar cautery use, should be kept to bare minimum, only where it's absolutely required. It raises the temperature of tissues you touch with it to as high as 400-500 degrees, and it is bound to cause some degree of necrosis, and necrosis invites infections.
Yes.
In this operation, the infection is totally unacceptable. It's absolutely catastrophic if you get it.
Yes. And this technique of posterior tympanotomy is one of the ways to prevent the infection coming to this field, as we don't violate the extra-aortic canal with the field. And this is very important to keep in mind. This is the extra-aortic canal. You can see the glimpse of extra-aortic canal.
Yes, we can get an idea where it is. So it should be well inspected and palpated. The anterior limit, don't have to breach it. That's important.
In case somebody happens to breach it, immediately suture it.
Yeah, repair
That's
it
the only
back.
way. So this way, minimum use of cautery, and I can see my anterior limit. Now, my implant is going to be housed here in the skull bone, and I need to protect the implant with some flap, musculoperiosteal flap. Now, for that flap, we need a separate incision and separate planning. What our proposition is not to make the incision lying over each other. Make sure that incision should not lie over each other. And that's what I'm doing here is the undermining of this posterior flap. More and more undermining, so that my flap incision for the musculoperiosteal flap will be at a different level. Let me show you. So making more and more space with a smaller incision with this undermining.
Satish, would you make some comment about the thickness of the flap?
Yeah, the thickness should be adequate for that matter. This thickness is variable according to the age of the patient as well. It should not be too thick or too thin, I would say. Both are hazardous. Too thick a flap can interfere with the implant, performance of the magnet and all that. And too thin a flap can lead to implant exposure, the necrosis and implant exposure. So both are hazardous. So that is very important aspect, sir has pointed out. The flap thickness is very important, and that is important in extreme age groups, in younger children and infants, and in elderly patients. Both are different aspects. See this more and more undermining.
So Satish, yes, sir.
Yeah, practically the hairline should not be exposed. I mean, if you different manufacturers has given different thickness measurement, instruments, but generally the hairline should not be exposed.
Yes, sir. See now, my lower limit, I'm making a horizontal incision here to make my flaps. I will tell you how my flaps incisions are not going to overlie each other. This is the lower one at the level of the mastoid tip. Then I will make a incision anteriorly on the cortex, mastoid cortex, anteriorly. Just anterior to that is the canal, without violating the canal. This is the anterior incision. I am making the superiorly based flap to cover my implant. So no incision will overlie the implant. That is our preferred incision. There are many ways to make the same incision. Many ways to make the same incision.
It's more of a posterior superior based, isn't it?
Yes. Away from the, little away from the ear, where my BTE processor will be there. So that is according to that.
So Satish boss, you have got I have got a link for questions, and you have got at least 50 greetings from all over the world. There are people who are wishing you from Pakistan, from Bangladesh, I can see, and from other parts of the world.
I am elated to have Kapil Sikka moderating this session to bring in most important scenarios, questions, and difficulties, and solutions for everybody. I'm happy that Kapil is here, and Kapil, with questions in your hand, I believe we'll have more and more interaction.
Thank you, sir. So I can read one question that is general for I think AOI office bearers. If Kaushal sir is there online.
Yes.
Someone is asking, is the registration fee for AOI Con 23 in respect of AOI and non-AOI members same?
It is a usual policy to have a different cadre for the non-AOI member, Kapil.
Right, but I think the things will be known as we approach the conference. They will be put on the website, I'm sure.
Yes. So at this platform, I request everyone to visit the website for all the details.
Yes.
Where the organizing team is requesting everyone to take the advantage of early bird registration for the upcoming AOI 23. And you can visit the website, and there is some special discount the team has offered during this the next couple of days from this workshop to encourage more and more people coming to the scientific event.
Yes, sir. That's Dr. Daroj from Solan. I think that answers your question, sir. They might be different. I think you can visit the website while you register, and the information will be put up there by the organizers.
So everybody, this is a humble effort from the organizing committee to start or initiate such workshop to promote our AOI Coin 23, to invite people for registration. That workshop, the AOI Coin 23, will be much magnanimous in terms of scientific activity. And here the entire team is inviting you to register for the AOI Coin 23 and make that conference like never before. So all are requested to go to the website and can do early registration for the benefit. Yes, Kapil.
Thank you, sir. So that's a very interesting and relevant question from Dr. Wahid from Peshawar.
Yes,
Satish sir, if you can take it, how do you check that hearing aid is not successful before embarking on CI? What parameters do you assess? How do you know that in this case hearing aid is not working?
Yes. So I told you in the beginning, one of the most important member of our team, or rather my CI program, our hospital CI program is headed by our audiologist.
Right.
So these patients require a lot of, audiological workup, a lot of sessions with the parents involvement session to see the progress of the children with the hearing aid, a lot of sessions by the audiologist to finally assess whether the hearing aid is working, whether the hearing aid is resulting in the speech, recognition, what is the overall progress of the hearing aid. So audiological criteria are different and defined by the audiologist, and those are more important.
Yes.
And our
so Dr. Wahid,
Kapil, our audiologist Ranju Verma is going to join us soon.
Right. I think it would be good to have her more relevant comments. So Dr. Wahid, in our centers, few of our centers, we have got separate rehabilitationists. In most centers, the audiologists are sub-trained as rehabilitation specialists who are involved in pre-operative and post-operative speech therapy, language therapy, auditory verbal training, and other things. So they need to be involved. How much benefit in terms of auditory perception, how much benefit in terms of speech improvement. how much benefit in terms of language improvement the child has got with use of hearing aid. If that is not reaching the standard landmarks of what should be age appropriate, then the decision for implanting is made.
Yes, yes. So one more thing here I want to bring to your notice. Once this flap is ready, let me know. Let me tell you what flap I have raised. See this superiorly based flap raised from the this mastoid cortex, and see this pocket I have made for the implant to go inside. Can you see this?
Yeah.
And this entire implant will be covered by this flap again,
right,
so as to prevent exposure. Now, if I reposit my skin flap, see this, my incision lines are not overlapping each other. Can you see?
Yes.
The skin incision line is falling here on the periosteum flap. See this?
Yes.
And these incision line for the musculoperiosteal flaps are away from the skin incision line. Can you see this?
Yes.
This is very, very important to prevent post-operative, wound complications.
Yeah.
See, one of the major, I would say, dreaded complication of the CI is the wound complication, infectious complications, and prevention of those complications. We need to, we should start thinking from the beginning, even from the pre-operative, workup point of view. We must immunize as per standard guidelines all patients before cochlear implant surgery for the required vaccinations like pneumococcal, H influenza, and other vaccination as per the CDC guidelines proposed by the cochlear implant group as well. And those have to be strictly followed by everyone to prevent post-operative infections to a certain extent. Then intraoperatively, we must follow the good surgical technique, optimum surgical technique to prevent infection, as we have been discussing, the flap raising, incision, use of cautery. Everything is important in preventing post-operative wound complications.
And don't forget the sterilization, your hand washing, your OT hygiene and other things. They are also very, very important and relevant. Very good points here, sir. One point that I would like to highlight, if you talk about failures, then the most common cause for failure of cochlear implant is infection. And yes, as you have highlighted, the finesse in surgical technique, finesse in the surgical hygiene, that's paramount.
And unfortunately, this infection can occur even years after the surgery, because this is a foreign body. This is a foreign body. Even a fault in the surgical technique, a lacuna in the surgical technique, can result into infection long after the surgery. If your implant is projecting unusually into the skin, if your, the skin flap, like Samdani sir mentioned, is not adequately thick, there's so many reasons which can lead later on to the implant exposure. In your surgical technique, if your implant is not adequately fixed, can lead to implant migration, which can be a disaster. So the proper surgical technique is very, very important, even for the delayed complications after implantation. That's why each and every step is very, very important. What we are doing, this soft tissue part, the implant fixation later on, every step is important in order to prevent complications later on. Kapil.
Very, very true, sir. Very true.
Now,
so there are a few greetings from Peshawar, Pakistan. Greetings from Dr. Mubarak sir. Mubarak sir, very good morning from all of us to you also. And a very, I think we have answered Dr. Panchal's question on counseling and consent in cochlear implant surgery. Dr. Sanjeev Joshi from Abu Dhabi is also viewing his, sending his greetings and saying it's informative.
Sanjeev Joshi is from Jaipur only. Our dear friend, he is shifted to Abu Dhabi.
Yes, sir.
He is part of the team of this AOICon 2023, as he has been part of the Mahatma Gandhi Hospital earlier. The Tarun Oja boss, the entire Mahatma Gandhi team is organizing this conference. And Sanjeev, you have to spare some time to come to Jaipur.
Good afternoon, Sanjeev sir, and good to know you.
See now, Kapil, what I have been doing.
Yes.
That is very important. This is doing some undermining of the soft tissue behind. See this. What
Yes.
happens once we raise this flap and put like this, when it comes to final closure,
Yeah.
the tissue retracts.
So some
Tissue
undermining
retracts.
will facilitate that closure.
Yes. And if you don't do this undermining now and start this undermining later, can lead to oozing, bleeding, which requires cautery, and use of cautery post implantation. We all know we try to avoid. We try to, something, our message is to avoid use of cautery once the implant is in place. So this kind of, mobilization of the soft tissue one can do in the beginning so as to prevent the tension suturing at the end of the surgery. This is very important. This doesn't take more than a minute, but this is so important because a tension suture can give way, can lead to implant exposure, can lead to infection and overall failure. A smallest mistake in this surgery can lead to a disaster. And see, we all know the cost involved in this surgery is important, significant. So taking care of each and every step is paramount for the patient benefit. See this, the amount of, see this amount of undermining I have done. Can you see? Hello?
Yes, sir.
See, this is without compromising anything. So this is important surgical step, undermining in the beginning of surgery to get a good post-operative closure. And here I can do more undermining anterosuperiorly. See this? The tissue is so lax. Without any tension, we'll be able to suture later on. Can you see this? So this is one of the very, very important aspect, I would say, from surgical technique to do this. Though it's a very small step, but very useful at times. Okay. So this is our initial part of, exposure to do further bone work inside. Can you put a suture and give me the BT processor? One more thing I would like to show here to mark you. The patient is going to wear the BT processor like this. See this? Can you see? This is going to be a BT, okay, BT processor like this, and we don't want this to overlie our implant. They should not come over each other, overlap each other to give problems. So what we do, we will mark this. We will mark this so that our implant will be, placed behind that. We'll be using a cochlear nucleus implant. Can you see this? This is a mark which I want to make here so that my implant will not come anterior to it. Then I do. Okay. Well, so this is for my further reference. Drill. This is for my future reference.